Okay, good morning. So this is chapter 39. This is disorders of the endocrine system, but not diabetes mellitus, everything else. So I'm going to share my screen with you and we are going to get started. Go. All righty. So here is the PowerPoint and follow right along. Try to disregard the lawnmower in the background. So what are we going to talk about? We're going to identify disorders that are caused by variations in hormones. Hormones related to the thyroid gland, parathyroids, and the adrenals. Remember, thyroid gland here controls your metabolism. Parathyroids are itty-bitty little glands right next to the thyroid. And the adrenals are a walnut-sized gland, one on top of each kidney. All right, pathophys, we're going to talk about what the etiologies are, signs and symptoms. We are also going to discuss the measures that we use to treat these disorders, how we assess them, and what the nursing care is for patients with these disorders. And then when we provide care, how do we know if it worked? Was it effective? All right, so with all of these, we're talking about there's either too much or there's too little hormone activity, okay, for lots of different reasons. And all these disorders, we're going to focus on the primary disorders. Secondary disorders are when something is wrong. You have a diagnosis of something because of something else, because of another disease. So we're not really going to talk about that. We're going to talk about the primary disorders. So first one we're going to talk about is ADH, antidiuretic hormone. And if a diuretic makes you pee, an antidiuretic makes you not pee, okay? And we have diabetes insipidus. Don't confuse it with diabetes mellitus. Diabetes insipidus versus SIADH, syndrome of inappropriate antidiuretic hormone. When you see diabetes insipidus, I want your brain to go, waterfall, okay? They don't have enough or even any ADH. And what they do is they pee and they pee and they pee and they pee and they pee. Even if they don't drink, they will continue to urinate. Their body will pull fluid from anywhere to just pee and pee and pee. And that's a problem. Okay? And then syndrome of inappropriate antidiuretic hormone is the opposite. Too much ADH. So they will not pee. Fluid retention is their biggest problem. Remember, with these disorders, where there are two that are the opposite, if you memorize one, the other is pretty easy because it's just the opposite, okay? Because both disorders have to do with the same hormone problem, okay? This is with ADH. You have too much or you have too little, all right? So with diabetes insipidus, they don't have enough ADH, so their kidneys won't reabsorb any fluid. So they will diurese. In other words, their kidneys will pull fluid and they will pee 3 to 15 liters per day. And their urine osmolality is increased. In other words, their urine just looks like water, right? What are the causes? Well, the most common is a pituitary tumor, sometimes a trauma to the head. Different types of surgeries, different types of drugs can cause it. But a pituitary tumor is one of the most common causes. Because remember, the pituitary in your brain is the king of your endocrine system and it controls everything, okay? So, signs and symptoms of diabetes insipidus. Polyuria, PPP, waterfall. Polydipsia, they're thirsty all the time. Nocturia, pee all night long. Urine looks like water. Then they will become dehydrated. They can even pee so much that they have pulled so much fluid from their body, it goes beyond the point of dehydration. They can put themselves into a hypovolemic shock and then change of consciousness and they're going to wind up dying. Please take note that with diabetes insipidus, you have 2 of the 3 Ps, not like diabetes mellitus. With diabetes insipidus, you have polyuria and polydipsia. With diabetes mellitus, you have those 2 plus polyphagia. They're hungry all the time. Here, this has nothing to do with food. This is all about fluid, okay? All right. So what do we do for tests? Well, we're going to look at the urine, get a urine analysis, and we're going to see specific gravity. It's going to be greater than 1.005. The big thing, and this is a board question, is the water deprivation test. So we send the patient to the lab, and they don't have anything to drink anywhere from 3 to 8 hours. I know that's a wide ballpark, but don't even worry about the time frame. Just understand with the water deprivation test, we deprive the patient of water. And while they're there, nothing to drink, but we measure how much urine output they have and what the specific gravity is of the urine. So a positive result is they just keep on urinating without anything to drink, okay? And the urine starts to become more and more dilute. And that would be, they have it. And how do we fix it? There's a drug called vasopressin, okay, also known as desmopressin. And that basically is antidiuretic hormone. It's a man-made ADH. And then, of course, whatever fluids they're losing, we have to replace their fluids with usually hypotonic IV fluids. But make sure you know vasopressin, okay? Some nursing diagnoses here: deficient fluid volume related to failure of regulatory mechanisms. And what is the outcome we're looking for? Well, we want to make sure that they are not dehydrated or hypovolemic. So urine-specific gravity should be within normal limits. Their skin turgor should be within normal limits. And by the way, when you are assessing skin turgor, you do not ever assess turgor on the hand, because as we age, see if you can see this, turgor starts to decrease on the hand because you use your hands a lot. Skin turgor is best assessed at the clavicle, right here. You just give it a pinch, and if it does not tent, it goes right back down, it's good. And then daily weights. The most accurate way to assess the fluid status, in other words, is this patient retaining fluid or losing fluid? Most accurate way is not I&O, daily weight. Not every other day, not weekly, daily weights. So with this patient, we are looking for their weights, daily weights, to be stable, right? Unchanged. That makes sense. And then SIADH is the opposite. So now they have too much of that antidiuretic hormone, so they're retaining fluid. Urine osmolality is decreased, and they're going to retain fluid everywhere, right? Lots of reasons. Nervous system disorders can cause it, some types of cancers, pulmonary diseases. Don't worry so much about the etiology of this, but just know that with SIADH, the signs and symptoms are the opposite of diabetes insipidus. So here, they're not losing weight because they're peeing all the time. Here, they're gaining weight. Generalized fluid retention. They have what's called dilutional hyponatremia. In other words, you're going to look at their sodium level, their serum sodium, and you're going to find it to be less than 135, because a normal sodium is 135 to 145. Here, because they have so much fluid, this sodium level is decreased relative to the amount of fluid they're hanging on to. So if you have 2 glasses of water, one has 8 ounces of water and one has 4 ounces of water. If both of them have a teaspoon of salt in them, the ratio of salt to water is going to be different for the 8-ounce glass versus the 4-ounce glass, right? There's going to be a smaller ratio in the larger glass of water. Same principle. They have so much fluid that their amount of sodium is low relative to the amount of fluid they're holding on to. Their urine is going to be dark. Don't confuse dark urine with amber urine. Amber is a normal finding for a urine analysis. Urine should be yellow to amber. That's normal colors. But here we're talking about tea-colored or coffee-colored urine, very, very dark. And then they're going to have muscle cramping, some weakness because of these electrolyte imbalances, and they can even retain so much fluid that they develop fluid in the brain, cerebral edema or swelling, which can lead to seizures and then death, okay? So that's diabetes insipidus versus SIADH, okay? And this one, diagnostic tests, we're looking at their serum or urine sodium, okay? And what do? How do we treat it? Well, what's causing it? If it's a tumor, get it out, right? We may put them on fluid restrictions, and we may give them diuretics like Lasix, furosemide, to try to get rid of that excess fluid, okay? And what are we hoping to achieve? Well, we're hoping that their daily weight remains unchanged and that their serum sodium, I forgot to highlight that, that one's important, stays in that 135 to 145 range, which is within normal limits. All right? Pretty easy, and that's that. Now let's move on to your thyroid. Thyroid hormone imbalances. So you can have hypo or low thyroid activity. You can have hyper. Just remember, hypo, low and slow. Hypo, low and slow. Hypo, low and slow. It even rhymes. Hyper is high and fast. Remember one, and you'll remember the other, okay? Because they're the exact opposite. So your thyroid gland is the only endocrine gland that is actually palpable, and it's right here in the anterior throat. You have the patient hyperextend their neck and swallow, and you can feel it. The thyroid gland is in charge of what we call your basic metabolic rate. So in other words, how much energy do your cells have to produce just to keep you alive? Like if I were just sitting here, just being, right? How much energy do I need to just keep my body alive? Okay, so that's your base metabolic rate. So let's talk about hypothyroidism, hypo, low and slow, the labs that you need to know. Thyroid hormone deficiency, right, is the pathophys. So there's not enough T3 and T4. T3 and T4 are low because it's hypo, right? But the TSH, thyroid stimulating hormone, which is one the pituitary gland makes, that will be elevated, okay? Just remember, when we're looking at labs relevant to the thyroid, the T3 and T4 are going to match the thyroid activity. So low thyroid activity, hypo, T3 and T4 are low. But the TSH will always be the opposite. Make sure you know that. Make sure you know that, okay? So with hypothyroidism, everything in the body is just low and slow. And it feels like the patient is trying to walk through pancake syrup or molasses. Everything's in slow motion. All right. It affects elderly women most commonly. And what's the etiology, the causes? Well, I mean, often thyroidectomy. If we take out your thyroid gland, well, you're going to be hypothyroid, right? But there are other reasons that are congenital. There can be inflammatory, autoimmune disorders. Don't worry so much about that in relationship to the thyroid, but make sure you know the signs and symptoms. If my thyroid is low and slow, hypo, I'm going to be fatigued. No matter how much I sleep, I'm tired. I'm going to have bradycardia, slow heart rate, low and slow, constipation, slow bowels, mental dullness. Just I feel dull because I'm so exhausted. Always cold, ooh, bradypnea, a slow respiratory rate, hypotension. My oil glands aren't making much oil at all because they're slow, so my skin and my hair is going to be dry. I'm not eating much at all, but I keep gaining weight, which can lead to hyperlipidemia, even heart failure. This is a very critical disease process, needs to be treated. So when we talk about complications, all of those symptoms that I just described in the previous slide, take all of them and then add severe edema, especially in the upper body. And you have what's called myxedema coma, which is hypothermia. So now my body temperature has dropped so low, it's dangerously low. All my vital signs are so low that I'm going to pass out, right? Severe hypotension, severe bradycardia, severe bradypnea, which can lead to respiratory failure and even death. Okay, so myxedema coma is all those extreme signs of hypothyroidism plus edema, and it's potentially fatal. Okay, and so what do we do to test? T3, T4, hypothyroid low, right? And then the TSH is the opposite, so it's going to be high. Okay. What do we do about it? One drug you got to know, levothyroxine, also known as Synthroid. You take this drug first thing in the morning with a full glass of water, nothing by mouth, no food, no meds, nothing, for at least 30 minutes after taking this med. And believe it or not, this is one of the few meds that I can say this about. Not a lot in the way of, side effects. Biggest problem is potentially a dosage that's too high, because that can push the patient in the other direction. So you're looking for signs and symptoms of hyperthyroidism. Okay? Right? And there's some nursing diagnoses for you. And then we have the opposite, hyperthyroidism. Fast and high. Fast and high. Metabolic rate. T3 and T4, they're up. TSH is low. Opposite of what the thyroid is doing. The thyroid's moving fast, so the T3 and T4 are high. The TSH is low. Opposite. Causes. The most common cause of hyperthyroidism is something called Graves' disease. Graves' disease is an autoimmune disorder. And remember, autoimmune, the meaning of that is that the patient's immune system, instead of protecting them from pathogens, germs, bacteria, viruses, right, it's attacking them and trying to kill them. So with Graves' disease, their thyroid is being attacked. And two of the classic symptoms are exophthalmos, and that is boing, the googly eyes, and then a goiter, which is just an enlargement of the thyroid gland, and I have some photos later in the slide. And what are the causes? It's not Graves' disease. It could be because the levothyroxine dose is too high. Don't worry about the adenoma and all those other things, okay? Signs and symptoms. Well, these are all the exact opposite of hypothyroidism. With hyperthyroidism, you are in a hypermetabolic state. In other words, your whole body is in overdrive. Think of a race car. You are hot all the time. You have an intolerance to heat because you're just hot. You are starving. Eat, but you don't gain a pound. Lose weight. Bowels are in overdrive, so you've got diarrhea. Your vital signs are in overdrive. Hypertension, tachypnea, tachycardia, to the point where they may feel palpitations, tremors, nervousness and anxiety, insomnia. I can't sleep. My skin and hair are super oily because my sebaceous glands, the ones that produce oil, are making a lot. They're in overdrive. And then the exophthalmos, like we talked about. There's the googly eyes. And remember, with this disorder, with Graves' disease, when the patient develops exophthalmos, it is because of a swelling of fat pads behind the eyes, behind the sclera, the whites of the eyes. That's what makes those bulging eyes. And it can get to the point where they can't shut their eyelids. And I'm pretty sure I mentioned that before, but make sure you remember that. So they're going to need things like lubricating eye drops, because their eyes are going to be super dry if you can't shut your lids, okay? All right. And then with elderly, it's even more worrisome because remember, the very old and the very young, they're the fragile ones. And so all those hyper things, right? Hypertension, tachycardia can lead to heart failure, AFib, even VFib, okay? Which is bad. And then the complication of this, remember, with hypothyroidism, it was all those symptoms to the extreme, and edema was myxedema coma with hypo. With hyper, same thing, a thyrotoxic crisis, also known as a thyroid storm, also known as thyrotoxicosis. They all mean the same thing. They are extreme hyperthyroidism that is so severe that they can die, okay? And with this, the symptoms have got to be treated right away. And because if not, the tachycardia, hypertension, tachypnea, high fever, dehydration, these things can kill your patient, right? So again, tests, T3 and T4, high, TSH is low. And we may do a CT scan or an MRI if we think that the patient has a tumor that's causing it. How do we treat hyperthyroidism? Well, methimazole, okay, which is also known as Tapazole, is the first drug that you need to know. Side effects of that drug are hepatotoxicity. So you should, as a nursing intervention, be checking AST and ALT, liver function. Can also cause agranulocytosis, leukopenia, or anemia. You should be checking a CBC as a nursing intervention to make sure that the patient, their white blood cells granulocytes and neutrophils, all of them have not decreased, and that their red blood cells and hemoglobin have not decreased. Okay? And then the other thing is, we're giving them too much of it, where we're pushing them in the other direction and causing them to be hypothyroid. Then, next drug, propylthiouracil. If the patient, for whatever reason, it doesn't matter, can't take methimazole, propylthiouracil is the drug of choice. Same side effects, same nursing interventions, patient education, right? But this drug is also used before a thyroidectomy. So if we're going to remove the thyroid gland, before we do that, we need to give the patient medications that include propylthiouracil and radioactive iodine to suppress thyroid activity, because otherwise, after the thyroid is removed, the patient can go into a thyroid storm, okay? And I'm going to explain that a little more lengthily a little bit later. But anyway, so methimazole, propylthiouracil, radioactive iodine is used to destroy some of the tissue of the thyroid gland prior to thyroidectomy. It's also used to treat thyroid cancer, but don't worry about that right now, okay? And thyroidectomy, like everything, we always do the most aggressive thing last. If we have tried everything, nothing's working, get rid of the thyroid, okay? So when I remove that thyroid gland, remember, the patient will be on levothyroxine for the rest of their life. Remember that, okay? And then if the patient's in a thyrotoxic crisis, again, remember I said treat the symptoms. So we need to lower their heart rate and blood pressure, beta blockers. We need to give them fluids because they're dehydrated from this high fever, IV fluids, cooling blanket to bring the fever down, acetaminophen to bring the fever down, some supplemental oxygen so they can breathe when their respiratory rate is 40, okay? Thyrotoxic crisis, treat the symptoms immediately so the patient doesn't die. Remember, please don't kill your patient. That's the doctor's job. There's some nursing diagnoses to go along with that. I am not going to belabor the radioactive iodine because we're going to talk about radioactive treatments for cancer and also involving this radioactive iodine later on in term 5. So just understand, when the patient is receiving radioactive iodine, the patient's radioactive, right? So in other words, they have that radioactivity in them. So stay away if you're pregnant. Kids should stay away, limited time with the patient. Their urine, any body fluid that comes out of them is radioactive, right? Okay. So there's a picture of a goiter, right? They can get really big, and that's the enlarged thyroid gland. So if it gets that big, probably need to get rid of it because it can cause difficulty breathing, difficulty swallowing. So we're always going to monitor their breathing. Remember what stridor is. Stridor is that crowing sound that is an indicator of obstruction of the airway. It's inspiratory and expiratory. So it sounds like this. That's the goiter pushing on the trachea so they can't breathe. That's when we have to get that goiter. Get it out. I am not going to talk about thyroid cancer because we go into great detail with cancer in term 5. Thyroidectomy, you're going to make sure preoperatively that we're monitoring their breathing and swallowing, vital signs, of course, and what they're going to be getting, some kind of anti-thyroid drugs, radioactive iodine, propylthiouracil, to achieve a euthyroid state. That is a normal amount of thyroid hormone, euthyroid. So you have hypothyroid, which is too low and slow, hyperthyroid, which is too high and fast, and euthyroid, which is just right, okay? And then after the thyroidectomy, you have potential complications. 2 of the big ones are thyrotoxic crisis and then tetany, which we're going to talk about in a minute. So thyrotoxic crisis, the thyroid storm. Remember, if we don't disable that thyroid gland before the surgery, then they're going to have all that thyroid hormone. And after the surgery and the anesthesia wears off, all of a sudden, blood pressure's up, heart rate's up, high fever, they're going to die. Treat the symptoms, right? And then the other post-op complication is, remember I said you have these two itty bitty parathyroid glands on either side of your thyroid that are in charge of a hormone called calcitonin. Calcitonin is the hormone that's in charge of calcium in your body. How much calcium's in your blood versus how much calcium's in your bone. And calcitonin can draw from the blood to the bone, or the bone to the blood, or the blood to the bone, or the bone to the blood to keep it in balance. Well, if during surgery the parathyroid glands get nicked, or they can even, they're so little they can get removed accidentally. Yeah, you heard me right. And the patient postoperatively will have symptoms of hypocalcemia. And the biggest symptom, remember, when you think calcium and magnesium, you think nerves, right? Nerves. It affects the nervous system. So they're going to have tetany, which is overexcitation of the nerves. Neuromuscular irritability. That's, right? They can have numbness and tingling of the fingers or around their mouth. And it can be so significant, they can have dysrhythmias because of it. Well, what do you do if you think that's what's happening? If I'm post-op after a thyroidectomy and I say, my fingers feel weird, tingly, you're going to do a Chvostek or a Trousseau, okay? Both of these are nursing interventions that you can do independently that will help to confirm if you believe your patient is hypocalcemic or hypomagnesiemic, but we're talking about calcium right now. Chvostek, C stands for cheek. You tap the facial nerve, which is kind of right under the cheekbone, and patient's going to go, They're going to have a twitch, and that's the tetany, hyperexcitation, okay? That is a positive Chvostek sign. And then you have Trousseau, positive Trousseau sign, which is where you put a sphygmomanometer on the patient, and when you inflate it, their hand will start to go like this. That's tetany of the hand, okay? And that is overexcitation due to low serum calcium, okay? So make sure that you understand these things. This is part one, and then the next part is going to talk about pheochromocytoma, which is always fun, Addison's and Cushing's disease. So that's it for now, and I'll be back. Stop sharing, and peace out.